we're really very grateful that people are joining today. Sarah, glad that you're here to help with any sort of questions or queries. My name's James Carter. I'm head of mental health programs for the South East, focused predominantly at the moment on community mental health transformation, and we have obviously a number of other colleagues on the call that I'm grateful to introduce today as part of this discussion, a wider discussion on transition. I don't have any, he says. You can all see my screen, correct?
Yep.
Great. So yes, what we'll do that we're going to go through today with a number of presentations, and we're grateful to colleagues and also Kate, who's joined us as an expert by experience today to talk about her family's journey living with and working as a family unit in their autism journey, which I'm really looking forward to hearing Kate's reflections alongside Nadia. We're then going to have an interesting conversation with via Gavin and Paul, although I know Gavin, I think, was just going to be away from for a couple of moments. I think he has another meeting that is running at the same time, where we're going to be talking about a specific case, an anonymous case, of course, of an individual that had been in long-term secure care, and how that individual, how the system reacted to ensuring that individual was appropriately and put into, given the care, sorry, I should say, in the community after a long period of segregation and secure care. So looking forward to that. Suba, Dr. Suba Mitalagu is one of our clinical leads across the Southeast, CYP, children and young people's psychiatrist, and has a long experience in understanding and trying to sort of reference what the CYP to adult transition looks like, and potentially give us some ideas and local case studies of how that works within her patch in Hampshire. And then Andrea, who I haven't heard from today. Now I can see she's there. I can see her little avatar there. So great to see Andrea here as well. In respect of transition, we've been having quite a large conversation, and Andrea has very much been leading on the front foot in the Southeast in this space on care leavers and the impact that those children in care and young people in care may have later in the system, due to previous experience, due to life experiences and so on. And it will be interesting to hear Andrea's take, both from a strategic and a governance perspective, but also really trying to let us, trying to get us to further understand both the complications, the challenges, and also the opportunities of working a lot closer with these with this cohort of individuals. So I hope this is going to be an informative session. I'm really grateful that everyone has put the time and the effort into putting their presentations together. We are recording the session. Please do consider any questions. We will try and get some time for questions down the line. We are recording this session. Thankfully, Sarah, I can see that has clicked through okay. If you do have any questions, please do add in the chat, and we will obviously pick those up as we go. I can't see Alison here, so I'm going to take a bit of chair's privilege at the moment and move us straight into the first session, which is Nadia and Kate. I'll go on to mute, guys, and bring you guys up. Just give me a shout when you'd like the next step that we've already discussed to come on. Okay.
Thank you.
Over to you guys. Thanks.
Thanks, James. So for those of you who might know me, who don't know me, I'm Nadia Baraka. I'm the Associate Director for Mental Health, Learning Disabilities, Children's and Families for East Berkshire CCG in the Freemley Collaborative. That is a bit of a mouthful, but I just thought I'd introduce myself. And Kate, would you like to introduce yourself?
Yes, my name is Kate Wilson, and I'm invited along to this meeting as a parent who has first-hand experience of somebody with autism and severe anxiety, who has had a very long and arduous journey through the system. My daughter's now 20 now, but we're on a good pathway now. So I wanted to share the good, the bad, and the ugly, as it were.
Very much, we don't have a presentation to share with you, but we have got something to share at the end of this. We've got 15 minutes on the agenda, and I didn't really want to take up much time apart from, and I really wanted Kate to be able to share her experience and voice her experience, like she said, the good, bad and the ugly, to really demonstrate how difficult it can be, how upsetting it can be, and also how positive it can be if we all work together. And Kate and I kind of had contact, kind of introduced at, probably it was nearly coming up to 2 years now, isn't it, Kate?
Yes.
Probably 1 3 years. We're on I think my first contact with about her daughter, Ellie, was an email from NHS England advising me that we had a week to move her out of a specialist provision because it wasn't safe for her. So that was my first encounter. And what I will do is I'll pass over to Kate to talk a bit about what happened prior to that and how we kind of got things back on track for her.
Okay, thank you, Nadia. Yes, my daughter's 20 now, so at the age of 5, she confirmed had a confirmed diagnosis of autism with severe anxiety. So there was lots of complexities going on around her needs. She was in mainstream school, and at her year 5 review, they said that she should stay mainstream. However, I think in hindsight, when you have somebody with autism, a complex sensory profile and the huge anxieties that my daughter had, a specialist provision then would have been a lot more appropriate because of the holistic approach to supporting somebody with those complexities. But unfortunately, she went to a mainstream school. She was very badly bullied. And that was when the anxiety, the autism, we then spilled over into mental health, became under CAMS. So she was about 12 and a half years old then. And we started an arduous journey of trying antidepressants, antipsychotics, lots of different reviews, assessments. Eventually, we ended up being transferred to the South London and Maudsley under Professor Santosh and his team, which was probably the most positive thing that could have happened for us, because they have supported us through this whole journey. Although normally children are discharged at 18, he stayed with Ellie and the team to see her into her home setting this year in March 2020. As much to see again, how these transitions, when we all work together, all of the services work together, you can have a successful outcome. And I think that's very important for the South London and Maudsley being a research centre as well as an epicentre for what they're dealing with. I think one of the things I've learned through this whole journey is that as a parent, I can provide an open platform to share information between the services, because the services, due to GDPR, patient confidentiality, do not have the openness to share. And I think that's where things could possibly fall down. As Nadia said, when my daughter was in one of the hospital settings that closed down, it was a CAMS unit. Because she was over 18 and had a special license to stay only in that unit till she was 19 once we sorted out her home. Unfortunately, the license didn't move with my daughter, Ellie, it moved with the provision. So when the provision closed, so did the license. And it became apparent then that Ellie was unknown to adult services because she had been stuck in the hospital system. She was completely off the radar. So if we go back to the sort of the journey in the hospital system, as I say, my daughter was in mainstream. It wasn't successful. She was taken out. She tried 2 SEN provisions, but unfortunately, it was probably trying to shut the door after the horse had bolted. The damage was done. The mental health was in a very bad way. And at the last school, Ellie was on quetiapine, which she had to be taken off because it was affecting her heart rate. And as we were titrating that out to start another medication, she had a massive psychotic episode. We ended up in A&E in the Royal Berkshire Hospital, where we were for 4 days whilst the crisis team were involved. They were trying to find a bed in a hospital for Ellie. There were no beds. At one stage they were talking about hospitals in Scotland, which was absolutely not going to happen. Because they were keen to get Ellie out of A&E because it was messing up their numbers on beds and things, we ended up in an adult provision in Reading Prospect Park. Ellie spent 6 days on an adult ward, bearing in mind she was at that stage still a minor. Again, the crisis team were looking for somewhere. And I think what happened is we ended up at Ticehurst. And it wasn't because it was deemed the most appropriate setting for Ellie, it was because it was the only bed that was on offer. And I think we were all completely traumatised by what was going on. We went with this idea of going to Ticehurst that Ellie would be, she needed to be in hospital to have a medication regime implemented that needed constant monitoring in the early days. However, when she was there, she was over-medicated and ended up in Pembury A&E on a drip for 6 days, treated for NMS. So when she came out of the Pembury Hospital, she went back to Ticehurst, obviously still not deemed a very safe place for her. And then we moved to a new provision in High Wycombe. And the idea of High Wycombe was it was very close to home. We could start rehabilitating Ellie back into community, back into school. However, when we arrived at High Wycombe, the consultant there didn't feel that the autism was a problem or the anxiety. He said that she had a completely different diagnosis of paranoid schizophrenia. So we got the team from the Maudsley down. Professor Santosh and his team came down, reassessed her and said, no, it absolutely is autism. It's a sensory profile in this environment, which isn't right for her. And that's why you're seeing these end presentations. But unfortunately, the consultant wouldn't work with the Maudsley. So we found ourselves in a situation where Ellie was 20 minutes from home, but locked in a secure unit and they wouldn't let her take her out. And while she was in there, she was very heavily sedated. That was a huge problem. They were just pumping her full of more and more sedation. So she was going sort of spiraling out of control. And that was the unit that came to a sudden closure. It was a Priory unit. It had a CQC report done on it and wasn't deemed appropriate. So that was hence the need for a speedy move and to get Ellie moved out. I have to say that the NHS contact who was responsible for Ellie in the hospital, he went above and beyond duty to make sure that everybody was made aware about Ellie's situation, and he actually called a meeting which involved Nadia and lots of other people to say, look, this young lady has had the most awful journey. Her family are on their knees. They need some help. What can we do? Then we started to plan and work together. Unfortunately, Ellie couldn't return to the family home because, number one, her medications hadn't still been sorted. Number two, there were safeguarding issues at home because Ellie had two siblings and she needed such intense one-to-one support that there would be occasions where it just didn't work. And prior to Ellie actually going to a specialist school, we'd had respite support in the home for 4 years of 20 hours a week. And it was just becoming apparent as Ellie became older that her needs, she needed more one-to-one support than we could provide in the family unit. So unfortunately, we were not in a position where we could bring Ellie home. She was transferred then to another Priory hospital. And it's quite interesting to actually just point out here, when Ellie's information pack was put together to see which gateway would be the most appropriate. So would it be a learning disability or would it be an autism? Ellie didn't reach the criteria for the learning disability gateway. So she went back to the normal gateway, which could only then offer a PQ. And two of the directors from hospitals who were sent her pack, to see whether they're suitable, phoned me up and said, a PQ is not appropriate for this young lady. It's too chaotic, it's too distressing. But they also appreciated that probably what we did need didn't exist. So it was a case of working with a hospital in the best way we could. I think because Ellie was trapped in the Priory system, the Priory and Burgess Hill were asked if they could accommodate Ellie. So they did. They cleared their de-escalation area and put Ellie in there because it was nice and calm and quiet. And the consultant or the clinical director there, Dr. Chatterjee, he worked with the South London and Maudsley. So it was a good transition. It was a good handover. I think because Ellie was now known to more people, there was a lot more communication going on so that we could all work together. Ellie spent, she went there in the February in 2019, and in the CTR meeting that we had in the March, My Safe Home was put on the table as an option to get Ellie out of hospital. I don't know if many of you know about My Safe Home, but it's basically a housing scheme that is part mortgage, part housing association, and part funded, to make up the money, the three sections of the house. So we then embarked on finding a house, accessing the scheme, and although it took 52 steps to get from A to B, none of the steps were hard, but they each had to be done in sequence. So there was a lot of chasing of letters and joining housing associations, and just sort of ticking lots of boxes to satisfy the realms of what My Safe Home was about. But we managed to, as I say, agree to that in the March. We identified a property in the July, and we had closed on the property on the 20th of December. And the property, the idea of the My Safe Home, which is so good, is that you can choose the house close to your family home if you so choose, or you choose the location. So we were able to choose a property for Ellie that was not far, 6 miles from our family home. So close enough that Ellie is still part of our family, but not so close that she's not going to start on her journey of independence as well, because that was another important thing. At the age of 20, it was about getting Ellie some security for her future, because while she was in the hospital system, I saw many young ladies who had been in and out of the hospital system, some as many as 8 and 10 years, because each time they were discharged, either back into family homes which couldn't cope to them, or care homes which weren't appropriate for them, they would end up back in the hospitals again. And I really didn't want that for Ellie at all, because it wasn't helping her. So we chose the location of that house, as I say, and it's close to local amenities. On her doorstep, she's got a community centre, which outside of COVID runs an autistic club, so she could walk there. Unfortunately, that's not running at the moment. Shops that she can walk to, country park. So community close to Reading, close to a cinema, good bus routes. So we kind of had a tick list, and that was the advantage of My Safe Home. We had the option to choose. So when we first got the house, I got an occupational therapist to do an assessment on the house, because it was quite clear that, having been in the hospital system for now 27 months, although in that time I did visit Ellie twice a week, and certainly when she was in Brighton for the last year, I did 22,000 miles in my car, going down there, picking her up, taking her to the cinema, taking her to Laser Quest, taking her shopping, just so that she didn't become so institutionalized that we wouldn't be able to integrate her back into her community. So that's what I said with the OT. The OT lady worked with Ellie, looked at her profile, looked at reports from the hospital, and we made the house bespoke to Ellie and very safe. So that when she was in there with the care team supporting her, that everybody was safe. Safety was the first issue, because I knew that it would take Ellie a period of time to relax and calm into her new environment. And certainly that has been proven the case as we wean her off the sedatives that she was put on in hospital. It's taken us 8 months. We're nearly at the end of that, and we've seen huge improvements as her mind is beginning to clear. The care team that support her, it's a bespoke care provider, and it's all focused around behavioural support, positive behavioural support. And they use a system called Nourish. I don't know whether you know of this system, where they input a lot of data, and the company has a behavioural support therapist who analyses that information, pulls it all together, and that then enables them to train and support the staff who are supporting Ellie on the ground. And it's proving very successful. I think one of the things we found quite difficult with COVID, the original care team, all those that had been identified, some of them then had to isolate, shield. So we had to start again. So it's unfortunate for Ellie really coming out of one restrictive environment into another. But luckily, with the park on her doorstep, she was able to get out and walk all the time and access her community, which is what it's all about. It's about her safely accessing her community and doing what she wants to do. I'm just aware of the time, so I'll kind of wrap up quickly. I think one of the things that I feel is really important is that a lot of autistic people with severe anxiety can't cope with chaotic environments, and a normal family home is chaotic. So a bespoke bespoke home approach is the way forward, I think, for a lot of these people. And I think they don't need so many medications, because the environment is what they kind of term a NIDO environment. It's built around the individual rather than the individual fitting into an environment. The environment is built around them. Essential that you have a bespoke package of care, and that the carers have training and knowledge in autism, because a lot of the behavioural sides of autism, it's a form of communication. It's not a form of bad behaviour, but it needs supporting and managing in a positive way. As I say, the house will give Ellie independence. She's still very keen to have an education, and her education and health care plan stays in place. So she has a tutor going into her house twice a week now. And the hope is that she will get to our local college, which supports children with special needs. She's still very much part of our family, so that's good. One of the things I would sort of say with all of this is that with this now in place, I feel so much better as a parent. I think, I can't bear to think for the families whose children have been trapped in hospital during lockdown. I think that would have finished me off, because the stress and the strain of actually having to undertake the journey, attend all the meetings, be a parent to other children, be a wife, run a house. It was like juggling so many balls in the air. And it's very stressful. So actually, by getting Ellie settled, it hasn't just saved one life, it's saved 5 lives. It's not just all about that one child. In a family, when you've got several children, you like to think you spend your equal time. But if you have one that is more needy, it does drain you a bit that way. As I say, I think one of the sort of lessons learned, I think, for looking forwards is that in hospitals, they have these lovely brochures about how they're going to do therapy and support, but a lot of these people, like Ellie, who are very complex, they can't access the clinical programs. They need to be probably more land-based, so it's done through animals, done through fresh air. So I think it's almost, I think I said to Nadia earlier that it's a shame that if children need to have a medication change that needs to be overseen in a medical environment, there isn't some kind of safe house for them to go to, where they're not mixing with everybody else. I mean the PQs. I don't know how Ellie spent an awful lot of her time locked up in seclusion. She was black and blue. She came out, her hair was matted to her head, and her tooth had been knocked out at gum level. So, and I'm not saying that somebody's deliberately going up and doing that to her, but they're not. The staff in these units aren't equipped to provide the level of care and expertise needed to navigate around people with autism and learning disabilities. It needs a very gentle approach. So when I sort of say about a safe house, it's almost like a cottage hospital that they could go to. So they could be monitored whilst they have these medication changes. Because unfortunately, I've been on working parties that sort of say, how can we avoid people going into hospital? I don't think it can be avoided sometimes. I think you try your best to avoid it, but sometimes it happens. And rather than put so much emphasis on how can we avoid it, we should be also looking about, right, when it happens, how can we better support it so that we get these people out of hospital quicker, and that whilst they're in there, they're not so distressed that the emotional trauma is really big. And I think it's just thinking outside the clinical box almost, because we all know that pharmacology does play a part when somebody's got such severe anxiety, because you can't leave it untreated, but you have to complement that with other things. So you've got holistic therapies maybe going on, psychology, psychiatry. It's about all the pieces of the jigsaw pulling together. And I think one of the other things really to mention with these types of units is that when you've got somebody in there with a learning disability or autism, the dosage of medication really needs to be brought way down, because they can't tolerate it at the levels that we can tolerate, or neurotypical people can tolerate it at. And it needs to be titrated so carefully. And I just don't think there is that time to manage. like that, and I think that's where it becomes a danger, that these vulnerable people, they're trying to communicate through behaviour that they don't feel well, they're not coping, but it's just seen as, right, they need more sedation, let's just give them a bit more sedation. So I think that's sort of a lesson to learn. But going forwards, Ellie is now out of hospital. We're supporting her with some bespoke therapies. We're going to show you a video, horticultural therapy, which is a therapy that builds on self-esteem, confidence. So we're rehabilitating Ellie now back into her community. She gets a lot of support from her care team, from her family. She also does a sort of a yoga massage thing as well, and I'm trying to also sort out some equine therapy, although I'm hitting a bit of a wall with that because it's not approved by NICE. The local authority are still sort of trying to say we need a more clinical route, but Ellie, we can't access a clinical route. She never has been able to, so that's not going to change now. But it's all really positive, and Ellie is enjoying actually becoming independent of us. Originally, I was getting phone calls 20, 30 a day. Well, I haven't heard from her for the last 2 days, so I'm going to see that as a good thing. And also for me as a parent, I think I've come out of this actually. Now I feel not too bad, but I think I actually came out of it quite traumatized, because every time I left, and Ellie was, you know, as I say, 75 miles away from home in Brighton, I felt for her safety. And I think when you live with that day in, day out, it does sort of grind you down. And I still sit here now and I think I'm fairly intelligent. I'm quite practical. I'm not very sort of academic, but I think, how did my child end up in hospital for 27 months? And I try not to labour on that, because even now I see it as a huge failure. But then when I break it down, when we were trapped in the system, you get swept along on this tidal wave. And we were lucky to get out. I just wish this My Safe Home, these bespoke packages of care in the community, was available to the many, not just the few. And that's what I said to Nadia. I'm very happy to talk to any committee and share my knowledge. It just seems that, you know, I don't believe if Ellie didn't have me coordinating all of this, it wouldn't have happened, because through the CTR meetings, there was a lack of consistency with the attendance of social workers, or they were chopping and changing. So you really do need like a project manager who is overseeing all the aspects of it. I mean, I did give up my job in was it September 2019. I just decided, right now I really have to focus on this, because it wasn't just the buying of the house, getting the assessment of the house. I oversaw the building works of the house, and I was beginning to feel, you know, I was hearing things about this COVID building. And I thought, right, Ellie wasn't due in her house until the 3rd of March, but we managed to get her in there on the 10th of March. You know, we kind of pushed the programme faster because we could hear this lockdown was coming. So I think that's what it needs. It almost needs a team of people in each region who can manage this process through. Because although you might not have loads of individuals, you do need to be on it the whole time. It's the coordinating of the benefits, the solicitors. Ellie does also have a mental health solicitor. I think that's really important for any youngsters who are experiencing problems. And she qualified for that under her section, when she was under section, and will continue with that now. So I think that's really kind of, I hope I haven't jumbled it up too much for you. I feel as I'm sort of racing around my tongue, but I don't know if anybody's got any questions.
I think it would be helpful to show, we've got a clip of Ellie as she is now, and bearing in mind, just under 2 years ago, probably some of the conversations were about her remaining in a hospital setting and there not being any other options. It's a real stark difference to where she is now. And it just shows you how much you can do if you've got the right coordination, that open-mindedness, of course, opportunities and money to support it, but really working together in partnership with families, it really, really makes it work. And that was the difference, I think, in this particular scenario. So absolutely. This just gives you a feel.
Yeah, I just like with money. As to the money, if you think in 27 months, a lot of that time Ellie spent in seclusion. So her hospital fees would have nearly been in excess of £1 million over the 27 months. And that can set people, I think that, you know, that I remember banging my hands on the table and saying, you know, we need some help. This is just ridiculous. All this money, we could have bought her a house. We could have paid for care for years and years and years. But as I say, you know, Ellie is actually better now than before she first went into hospital. I think she's coming along. So I'll let you crack on with the video.
Okay. All together now. Raking, raking, raking. Raking, raking, raking. Raking, raking, raking all the leaves. Ellie's doing raking, raking all the leaves.
Thanks, guys. That's really lovely, and thank you, Kate, for taking the time to speak with us about Ellie and the experiences that you've gone through as a family. You know, it sounds as though that there were horrific times during that period, and that, you know, the way that you persevered both as a family and also, you know, how when the system comes together it really does work, you know, and there are opportunities to move that forward. There are a number of comments in the chat, Kate. I don't know how often you use Teams, but if there's a little there, and if you click on the speech bubble, you'll see a number of comments there. But we're very grateful to you for leading this bit of the session, and it's so important to hear of individuals' patient stories, and you know, and the processes and the way that you've moved things forward. And it is fantastic to hear that, you know, Ellie is, you know, finding her independence, and also, you know, that sort of element of both bespoke, you know, bespoke training, bespoke housing, you know, all of those elements are important. And there's a few comments in there that if you'd be happy to comment on, that would be great.
Lovely. And I'd also like to say as well, James, is that when we were at rock bottom at High Wycombe, when we had that 10-day, you know, what the hospital's closing, we didn't know where Ellie was going. But as I say, there was a gentleman who works for the NHS, who works with Nadia, Matthew Carr, who went above and beyond. I can tell you he was absolutely fantastic, because he actually had no duty of care towards Ellie because she was over the age of 18 by then. But he made sure every single one of those patients was housed somewhere, and he did it in such small time frame. The odds stacked against him. And then also for bringing Nadia into the picture, because he said we need to get this people involved who are actually going to do something about this. And he said, I know a lady who will get involved and will do something about it, because I think it's all very good sitting, sharing, talking, but people then have to go away and act on things, do things. And I know money's always you know, a big part of that, but it's actually having the voice on the platform. And Nadia listened and took it on board, and made a big difference. And I think it's where there's a will, there's a way. And I feel sorry for the NHS, really, because there are some really good people trapped within it, but sometimes they're not being allowed. I mean, look at Ellie. She was trapped in the priory group. That they're not NHS people. They're priory people, and it's a shame. You have very little control, really. We have all these procedures and things in place, but there's a lot of lip service going on from their end, I feel.
Yeah. Understood, Kate. And you know, we do have a number of individuals from across the southeast here on the call today that will be picking up on your story. Indeed, if you go and look onto the chat there, you will see that you know, senior individuals within the system are using this as an opportunity to do some reflection as well. So, you know, it's really important, Kate. I'm sure Nadia and yourself will stay connected. Nadia, thank you for you know, bringing Kate and Ellie's story, as well as the family story, more importantly to this group. We really do appreciate it. And of course, if there are further onward conversations, Kate, that we could link you in with across the southeast, and I'm sure we could have further discussions through yourselves, Nadia, etc. Okay.
Lovely. Thank you very much.
Thanks so much. That's really great. And all the best to you guys for Christmas, and to Ellie as well.
Yes, and to you and your family. Yes.
Thank you. Thanks, everybody. Great. Gavin, I can see you're here, and Paul was on earlier, so he's just showing his camera now. Kate, if you feel like you want to respond to any of those conversations in the chat, please do. If you don't mind going on mute, that'd be great. And over to Gavin, and he will introduce Paul as well and talk us through an interesting case study in regards to longer term segregation and secure care. Thanks.
Thank you, James. So the similarities will be apparent to the story you've just heard here, but what we want to, Paul and I want to get into is a discussion or a description of a process that we're trying to use where we take on the most complicated and challenging cases that we find in secure care, frequently people who we might consider not being suitable for a secure environment, and people for whom reputations have driven experience, shall we say. So just to do an introduction, my name's Gavin Thistlethwaite. I'm the programme lead for the Learning Disability and Autism programme for specialised commissioning in the South East region. So that is commissioning for secure hospital care and for CAMHS Tier 4 services. And Paul, my colleague, is a case manager. Paul, do you just want to introduce yourself?
Oh yes, I'm Paul Tossey, case manager. I formerly worked until very recently for NHS England, so Gavin was my boss basically. And I worked for the Provider Collaborative, but in a case management role. So yes, and I know Matt Carr very well.
Yeah, we both know Matt. Yeah. Could I move on to the next slide? So just to quickly introduce, Paul's going to be doing the talking here. I just wanted to give us context for this. So we have within the current system, there's about 135 adults with a learning disability or autistic spectrum condition, or both frequently, who are in the secure care system. That's either in low, medium secure or high secure systems. Frequently these are people who've got complex histories and have often been involved with the criminal justice system. Many will have actually committed quite serious crimes. And there's a history here around people who have got what you might describe as challenging presentations, but actually have got frequently very distressing stories of trauma, of unhappiness, of not having their needs either recognised or met, and often get stuck into patterns and behaviours and cycles of behaviour which are very difficult to be with and end up being incarcerated or contained. And frequently you then end up with myths associated with individuals, legends almost about them. Their reputations precede them wherever they are discussed, and it becomes difficult to talk about how they may have a life outside of a contained hospital environment. And one of the things we want to get into is exploring how someone might be able to get a more fulfilling and meaningful life outside of that setting, and actually the mere change is a good thing. The hard part is, of course, is making that transition happen. There is a trick to this, and that trick is working out how to do the planning and the development of that in a way that is safe and isn't likely to fail and end up back where we started. The key here is planning, good planning, where the time is taken to do it properly, that it's done jointly with the people, with a range of people who have got a role and responsibility in this, but starting with and always about the person themselves and their family. And then persistence. This is complexity we're talking about here. Just because you've decided that a plan is going to look like this, it doesn't mean it will work first time. And you have to be able to reflect on experience, learn about things that have gone wrong, and adjust your plan accordingly. And these processes are crucial and fundamental. I'll now hand you over to Paul, who will tell you a story.
Hi. Thank you. Can you click over to the first slide? First of all, I wanted to thank, it was really nice, the first presentation, and it does kind of link to some of the situations we've found. So I wanted to, and it's nice to see Suki and Nadia on the call, friendly faces as well. This is a discharge which was quite a while ago, but I wanted to present it because a lot of the systems we've used have been very, very similar as well. And I think family involvement was absolutely key. So this was kind of work undertaken, which was pre the FIND team, and we now have a FIND team, which helps a lot. So this is around Jane, who was placed in a secure unit approximately 80 miles away from her family. I first became involved because Gavin pointed me to look at and support these individuals leaving hospital. So she was in a secure unit, and they were looking at stepping up the level of security, which was quite worrying, considering that she was on a civil section. So we were heading up from low security to medium security. The provider felt they could no longer cope with that person. They were even talking about another hospital even further away. The local authority felt they had no provision closer to the home area. And there was a real ongoing discussion and disagreement between everybody around diagnosis. You know, a PDA, the family felt very strongly. Some members of the team felt ASD, and the clinical team felt there was a diagnosis of personality disorder. The main thing for me is the individual had long periods of seclusion. We're talking the seclusion room had almost become, you know, the default position, and she was also being nursed in long-term segregation. There was real challenges, I felt, with the clinical team. When I went to visit and assess her, it almost felt that Jane had become almost an object behind a steel door being viewed through a glass panel. And it was quite shocking. And I've worked in secure units for many years on and off. And there was also lots of charges pending, which could escalate up to another section, section 37. And there was really extended periods of seclusion. And the medication, it was something that was in the first presentation, was I felt the person was quite overly medicated, and it wasn't actually achieving anything, to be totally honest. I've probably put medication down twice because there was a real mixture of antipsychotic medication and benzos as well. I don't think that was working at all well. So everyone was stuck. Next slide, please. Yes. I felt we had some really positive CTRs in the fact that we got the right people at the CTRs. But one of the key recommendations was life planning. And I have to admit, at the time, life planning was something that was relatively new to me. And we just needed to review the whole LTS. As mentioned in the previous presentation, hundreds of thousands of pounds were being spent on supporting this individual in seclusion and LTS, but they were effectively 2 or 3 members of staff sitting outside the seclusion room door and then going in as a team to do the basic activities of daily living, i.e. feed someone. And it felt that the money was being spent ineffectively. But the main difficulties, and it was building up a relationship with Jane's families, is there was a total lack of engagement with the families. Basic things, when they were waiting to visit their daughter, there was no seats in the waiting area. You know, so they were left standing and in a corridor for long periods of time, and there just wasn't a degree of engagement. So so we did a whole row of CTRs, and Gavin will be, but we involved I'm out of here, and this formed the basis of a specification working to the new home. It also gave the family and Jane a degree of hope that things would change. All Jane could see was she was stuck with pictures of cats in her seclusion room, and she couldn't she wouldn't be able to get out, and this would never happen. So why should she work with people? So move on to the next slide. So the highlights of the CTRs, which worked in conjunction with the life planning, were a lot of the issues which were discussed around getting Jane her own home, moving plans, and also a lot of the work needed to be undertaken with a responsible clinician. The responsible clinician was so worried that if Jane went into the community, they would get into trouble if things went wrong, and why have I discharged this person? I spelt right wrong. Jane house rules for a new team, and also looking at dolls and how we would use that correctly. And also start thinking about how we could support Jane in the community as well. I think that was really important. And also looking at the new team, the specification. We did have some providers out there, but the focus was very much about Jane being in her own home, not improving enough so she could be stepped down to a lot of rehabilitation. So I felt there was a real key for involvement with Jane, her families, and this really started as part of the CTR. The family had a very long session in the CTR, and I think they made the clinical team feel quite uncomfortable, but it was a good opportunity to have those meetings and be very open. But it also gave the clinical team the opportunity to express their anxieties. So I think a lot of it was around process, CTRs and CPAs, keeping on top of the action plans and support in relation to tenancy agreements, and to support Jane's understanding that there would be a future going forward. Next slide, please. So we kind of moved the EPC. There's a thing that NHS England do, is the extra package of care. So this says if someone is 3-to-1, we will pay 3-to-1. But we changed the extra package of care, that it moved its focus from being 3-to-1 sitting outside the seclusion room to 3-to-1 actually going out of seclusion and doing meaningful activities. I think a lot of the CTR panels really helped with how we can move this forward. And there's also, we needed to do, again, very similar in some respects, a training plan to support the hospital team when things were not going well. For me, as a case manager, it's just making sure that we kept on top of it. And I was grateful to be allowed the time actually to, chase the CPAs, chase the CTRs, have almost weekly meetings with the family and Jane, and to link that, and we were able to identify a provider. But we also, a lot of the staff were very worried about allegations being made about them. So how we could support the allegations were investigated, but no unnecessary suspension would take place. Practically, they were worried that if they went out into community and Jane made allegations about them, that it would get so out of hand and everyone would be suspended. And we knew that if we could move the whole concept forward and more positively, it would change. Next slide, please. So for us, there was a lot of work. I think the family and Jane were really, really key. The Section 17 leave, just get out of the hospital, was challenging, but also reaching the stage of we're going to go on Section 17 leave to the new provider, and to provide the RT some assurance and bring them along and the clinical team. I put the future Christmas and cats. For Jane, it was very important that she was out by Christmas. And also the cats were a really, really big deal. I remember having to take photographs of my cat and bringing it in to Jane. And that feels really, really, it was really good. But the main thing for me was walking up the drive of her house. There was an extended period of Section 17 leave, looking in the windows and seeing the cat sitting there, and then seeing Jane in her own home. So the support for my out of here, the life plan, provided a format and a template for, Jane's hope, essentially. We've moved forward a little bit. We're now under the provider collaborative, and I feel the FIND team will take over a lot of the roles where I was chasing around and pushing, and that's really, really good. The big changes that have happened for Jane now is over time is she actually said there was quite a high degree of support in her own home, and the thing that changed is she actually said, I don't want the carers in my home anymore. This is my home. And everyone went, oh no, this is terrible. Is this a recall? We're going to have to bring her out to hospital. But actually, she was right. She wanted to have her own life. She wanted to get engaged. And she also had the right to make poor decisions. So sometimes some of the decisions weren't brilliant. She got banned from bingo. And, you know, and I had to say, I'm really, really sorry, Jane, you have to suck this up. You were banned from bingo because you were really inappropriate. And I think these were skills that she's developed over time. So this has proved really, really effective. It significantly changed my practice, as Gavin knows, and wish Nadia was still on the call. But again, we use this model with some other discharges, and it worked really, really well. I just think it's hard work, but the life planning was key. And so
Sorry, Paul.
Yeah, that's it, really.
Yeah. So just to summarise, Paul, actually, could you go on mute? Yeah, so just to summarise this, then the key thing here is this is taking someone who was identified as being a problem, had a description of them which was not recognisable really to the family, and a plan which led to what would have been an inevitable longer length of stay and an almost certain set of contacts with the criminal justice system, and change that around. Paul's leadership on this was crucial, but the intervention using organisations like I'm Out of Here to enable a process that isn't us, that is supportive of the family and starts with the person, is the thing that leads to the change. Now, Paul slightly glossed over this, but he's had to work really hard since she was discharged from hospital and therefore no longer on his caseload to keep her where she is, in order to make sure that that plan is updated and reflects the new reality for her. Now, the time has passed and we're much more confident that it's a stable process. But the key thing here is to not assume that we've made it, you know, that our judgment in the first place is the correct one, i.e. she needs to escalate through the system, and B, once we've washed our hands of a process, we've done what we need to do, that we don't just abandon it. And I think that the lessons that we've all learned in this as a system have been incredibly enlightening, and has shaped what we are going to be doing, what we are doing now and will carry on doing in the future.
Gavin and Paul, thank you very much. Really interesting to hear the counterpoint sort of with Kate and Ellie's story there as well, isn't it? You know, to sort of understand the distinctions and how the work there. And it was interesting, Gavin, I think you sort of brought that together with the comments around the need for sort of sustained and, you know, committed energy. Kate also referenced that the things changed when, you know, there was a much sort of more coordinated and, you know, sort of collaborative approach. Sounds interesting that these new models, I won't pretend to know what the FIND team, you know, are fully involved in, but certainly it sounds as though they're much more aligned to that sort of personalised care element and also the support via the family as well. So I hope that's an interesting sort of like I say, counterpoint with Kate and Ellie's story as well, that, you know, that we're listening and that we need to really try to embolden and try and enable that much sort of closer working together with our families and with individuals in a bespoke manner. So thank you. And cheers, Gavin. That was really helpful. Thank you for bringing Paul in. Paul, much appreciated. We're going to switch gears. We're going now to Suba, Dr. Suba Mutalagu, who is one of our clinical leads across the Southeast. Hi, Suba. I can see you're on screen. That's great. I'll whiz through the slides as you ask. An interesting, you know, slightly different take here. Obviously, principles may well be drawing out, we hope, that are common and generalizable. But Suba, over to you.
Thank you, James, and thank you to everybody to give me this opportunity to talk. Transition is, I'm quite passionate about transition because this is something, as a clinician, I'm also a consultant child and adolescent psychiatrist in CAMS team, New Forest CAMS team, and I've experienced this firsthand as a clinician trying to help young people to transition from children's mental health team to adult mental health team, and it's been quite difficult. So I thought, let's start with the basic things that we understand with transition. I know we all know, but sometimes it's helpful to just, remind ourselves. So transition is defined as a purposeful and planned process of supporting young people to move from children's to adult services, as per Getting It Right for Young People's document. And sometimes we get transfer of care kind of confused with what transition is. So basically, transfer of care, as we know, it occurs at a set point in time, but transition itself is a prolonged process, and it requires coordination of care, information provision, and documentation of the proposed care and support for the young person and their families during the transition period. And effective transition requires professionals understanding each other's roles and responsibilities and working flexibly. Next slide, please. So this is some pictures here. So, as a clinician, we assume that it should be straightforward. We refer, and the journey's straight there. But the reality is there's lots of peaks and valleys and trenches and all sorts of things that go through that. Sometimes our referrals are accepted and we get amazing support for young people. Other times it's just goes nowhere, and it's a struggle all the time. And unfortunately, in all of this, the young people are lost in transition. Next slide, please. So I wanted to go through a couple of case studies. And these are called A, B, and C, D, not real names, and both are girls, but with slightly different issues. So the first case study, AB's 17-and-a-half-year-old girl, was first referred to CAMS and admitted to the local general hospital following self-harm. And she had a history of past sexual abuse, complex family dynamics, struggling in education, and also had low mood. After assessment, she was admitted to a generic CAMS adolescent inpatient unit on a section of Mental Health Act, that was Section 2. And later she was diagnosed with PTSD, that's post-traumatic stress disorder, anxiety, and mild learning disability, and was deemed as a vulnerable young person. Following this, she was transferred to an LD adolescent unit, which was out of area, so away from family, and she was on Section 3 of the Mental Health Act, and then she was discharged into community around her 18th birthday. So this is, as we know, it's the worst time for young people for such things to happen, but it invariably happens because that's when young CAMS and AMS, there's a cutoff at 18. So her care initially was under a children's social worker. And then what she really wanted was to pursue her college studies, like life skills course. Unfortunately, a temporary accommodation was found, which was, again, out of area. And there was somehow her support for education was missed. Which then led to her basically self-harming and not having structure and having a number of incidents in the local general hospital, so leading to placement breakdown. The adult social worker then identified a permanent placement, and this was another area. And as the CAMS consultant, it was very difficult for us to then identify and work with a particular adult team because we didn't know where she would be placed. And this was a feature right from the time she went into the inpatient unit and then coming out into temporary accommodation, going back to a general ward and then back to a different unit. So This was unfortunately no one's fault, but this is where care leavers, you can see, as a particularly vulnerable population that suffer, and add to that learning disability and other family issues and parental mental illness and so on. So it was particularly difficult and tragic. I've put some names of key stakeholders there who should have been involved. Who were involved. I mean, in the end, we were able to talk to the community mental health team and draw in the community LD team to carry out a joint assessment with the input of local authority, the social worker, and identify the best placement with the support and discharge her to the local team. But that was not a straightforward issue. So in this case, the people that should be around the table are the CAMS and the AMS, that's the Adult Mental Health Service, the Adult LD team. IAPT stands, it's the local service that she can access counselling, which is not necessarily under a mental health team. And the crisis team, that's both in the children's and adult services, acute hospital, the inpatient unit, the social care, both adult and children, special education needs team, safeguarding teams, voluntary sector, and then commissioners and providers of all this, not forgetting the young people and their carers. And on top of that, someone who's an inpatient on a Section 3, there's a additional document of Section 117 aftercare, and also the CETR process. So this gives an idea of the kind of people who need to come together and support a complex situation. And next slide, please. The other case, again, similar presentation at 17 and a half with complex mental health difficulties, a young girl with eating problems and weight loss and difficult home circumstances, including parental mental health difficulty and substance misuse. So she was referred to CAMS, needed inpatient admission, and for a short while she was discharged to the community. And the CAMS team tried to refer her to the eating disorders team, the adult eating disorders team, who initially didn't accept her, but later on agreed to take her on. And they sent an appointment letter, which the young person did not like the tone of the letter, so she declined the transition plan. Unfortunately, 2 weeks prior to her 18th birthday, she ended up being admitted again into the general hospital with this time physical symptoms secondary to her eating disorders, requiring treatment. And at that point, because of the time that she was admitted, CAMS team explored potential admission to either a children's, the CAMS ward, or the adult ward. Unfortunately, this was not possible, and she remained on the pediatric ward, and the adult mental health crisis team and home treatment team were invited to again jointly assess the young person as she was turning 18, and again initially they declined, and the reason they gave was because their service was not commissioned below 18 years, and during this time, the young person's mother refused to take her back home because she did improve, as she was not confident with the care that her daughter was receiving, and also there were family issues. So unfortunately, she was stuck on a medical ward until the local authority were able to find a suitable accommodation, and safeguarding teams were involved, and it just became quite complex. So again, you can see a number of stakeholders need to be working together. And as a result of this case and learning, the local CAMS and adult service and social care decided to form a group to pilot some cases where the young person presents with these complex difficulties, including social care, to make sure that the issues are addressed early on, and and that all organizations work together. So that's an ongoing process. Next slide, please. So in terms of what I've observed over the years in this field of work is, and this is not just my observation, this is quite common in, where one looks at transition, is that services are commissioned and delivered differently in different areas. And there are different age criteria, different approaches to transition. For example, that CAMS, if they're willing to work just beyond 18, you would expect that adults can start working before 18, and there are teams that work that way, and there are other teams who are very rigid in how they approach this. And again, each organization has its own drivers and priorities. So, see someone early, but only after 18, and discharged, and that is quite difficult for the young person and the families when they're involved in the middle of this. And the expectation of children and adult services to engage in a common care pathway, especially if the teams are not under the same mental health trusts. This can be particularly difficult unless there's expectation of the two teams to work together. And then you have staffing resources. So training, supervision, and implementation can be complex. And the young people, especially care leavers, those involved in youth justice, ASC, the autism and learning disability as the comorbidity or the main issues, ADHD, substance misuse, etc. Young people with those difficulties can be particularly affected because they're not similar services in the adult sector as there are in CAMS. And in the middle of this, mapping all the local services that potentially the young person can access post 18 can be complex. Next slide, please. So this is the model that, the young person in the middle with all the essential factors, that's mental health and well-being, needs to be addressed. So this approach of young person-centered approach would really is really key when we are planning transition. So looking at their mental health needs, social care needs, physical health and well-being, as well as education and employment, rather than only looking at mental health or social care. Next slide, please. So we in Hampshire have developed a number of documents to support the transition, and I'm not sure, James, whether you can open the Hampshire protocol. Probably not. No. Oh, sorry. Okay. If you go back, it jumped. If you can go back, please. Yeah. Yeah, that one. Okay, so we held a number of stakeholder events involving all the key stakeholders that I'd mentioned, and designed agreed a multi-agency transition care protocol that was signed by the heads of all the services, and established a transition steering group using a well, we also had the young person and carer rep in there, and we had a one-page transition care pathway, a young person designed My Care, My View tool that captures their wants, wishes, and who they would like to be part of their transition journey, and so on, and also had the discharge questionnaire and audit designed, which really was timely with the transition sequence that was implemented for 2 years, and that was a really good time to help develop the relationship between CAMS and adult services. Unfortunately, since the sequence has come to an end, this has become less of a priority for in some teams. Next slide, please. Next slide. Okay, so Cornerstone for success, as we've heard from other speakers, transition needs to be started as early as possible to make it really work, to help us to have the time, and also for young people and carers to understand what they're going through and what they can expect from services, and definitely flexible working between the CAMS and adult services, so that we work in the young person's best interests, as opposed to how the services are configured. And agreed period of joint working between the CAMS and adults mental health and LD services involved the social care and special education needs, voluntary sector, etc. as appropriate is important. And working with other partner agencies when the young person needs are not seen as meeting a criteria for a mental health team, for example, is another important aspect. Hence, in steering groups or best practice group involving the local voluntary sector is important. And establishing transition link workers in each of the team is key, because otherwise it's left to goodwill of individual clinicians. And this, again, has been quite key in how our transitions have worked well. And establishing local multi-agency transition best practice group can take things forward, where one can discuss the challenges as well as the gains and good practice. And not forgetting the primary care, because many young people from CAMS do get discharged to GPs, and it can be difficult for primary care to then navigate the system with the young people. And the key is commitment from all of us to make it work for young people going through transition. Yep. Next slide. So that's so what this slide is basically showing is, sorry, it's the picture's gone a bit haywire. The straight line, although it's not the straight line, that we can try and make the journey as smooth as possible for the young person, and it's so that they can be themselves and have less of a worry of everything else that goes on around them. That's it. Thank you very much. Any questions?
Thank you, Suba. You really bring the points that we've heard earlier about complexity and the intersections of different teams really into gear there for a lot of people that are transitioning between children and young people's adult and adult services. You also make a very valid point around how important it is that the individual and the families are at the centre of that care as well. So the opportunity there for us all to be learning from each other is important. You also raise a good point about some key cohorts, including care leavers, and we're going to hear from Andrea on that in a moment. So thank you for almost sort of bridging a bit of a gap there. If there are any questions, I'll just check, but I didn't see any pop up. Let me just see. In the chat, Suba, there's a couple of things there. I'm just trying to see. My eyesight is not as good in the dark. No, nothing at the moment, although I do understand that there are those conversations about how best to create an open and honest platform for services to share information, in individuals' best interests. And you made the point about there being other systems involved, other providers involved right across the board. So trying to tease that out, I think, would be quite an interesting point on that. But thank you so much for taking the time, Suba. We appreciate it.
It's Lila. I've got my hand up.
Oh, Lila, I can't see you. That's why.
That's right. I just want to add that there's a really good guide on SCIE for transitioning from CAMS into adult services. So that's worth looking at, and I think that could comfortably include young people who have autism and/or learning disability. They're quite sort of the same themes, really. And I think the other thing that we should challenge ourselves to think around is, should adult mental health services operate more of a Thrive model like children? Trauma-informed thinking rather than diagnostic-led, and maybe thinking about adult social care around instead of chronological age, but actually thinking developmental, because the cohorts we're talking about typically will not be your average 18-year-old and might operate more like a 15, 14-year-old. And legislation doesn't take that into account. I think just a few things for us to take away and think about, and also how do we start applying personal budgets and personal health budgets much more effectively for these complex young people.
Yeah, good points. Would you mind if you've got the link to? I'm sure there are colleagues that know about those frameworks, Lila, that you mentioned first off. Would you mind putting them into the chat, or if you've got a?
Yep, I'll do that now.
That would be good. All right. Thanks, Lila. Nice to see you. I haven't seen you for ages. And Suba, thank you so much. We'll go on to Andrea now. Andrea is our local authority advisor across the Southeast. We're very fortunate to have her experience both from a local authority and also commitment to ensuring the safety of children and young people in systems. So we're grateful to Andrea, not only as a core member of our team, but also giving us a little bit of insight into care leavers, care leavers and those children in care that are potentially at risk as they move into adulthood. So again, Andrea, I'll hold the buttons, so just give me a shout. Okay.
Thanks, James. That's much appreciated. Colleagues, I'm really mindful that it's the end of a long day and many of us will have other meetings to go to, so I'm going to be brief and succinct. You'll know that we've been working across Southeast with every Director of Children's Services, every lead member, every designated nurse for children in care, all of our CCGs and all of our providers to try and create different arrangements for our children in care for whom we're parents for these children together. So what I want to do is just give you a bit of an update of where we've got to with that work. And secondly, then just talk to you very briefly about what that means when those children become care leavers, because that's absolutely crucial for our community mental health planning and for our 0 to 25 thinking. So just in sum up, this is the first time the whole of the Southeast region has cooperated at this leadership level on such a vast project for children in care, and it really follows the experience of some of our children at the start of Wave 1 lockdown who were deprived and denied basic mental health assessment and treatment when they were placed not in our region but outside of our region, and roughly a third of our children in care are placed outside of our region because of their very specialist needs or because of just problems with provision. We haven't got enough provision in the Southeast to accommodate them all. You might remember that we'd analysed 800 of our children in care cohort not long before Wave 1 lockdown actually, and we were looking at what's the cost on average for these children a week just for their social welfare budgets and needs, and that's about 2.4 million a week for these children. It's about 126 million a year just for 800 children in care, and of course we've got thousands of children in care. So we've been working with Southeast Sector-Led Improvement, the Local Government Association and the Association of Directors of Children's Services to say, can we together agree on some common principles, values and ways of working that always prioritise these children for whom we're the parent for mental health assessment and treatment. So on the next slide, James. Thank you. What you'll see is the kind of way we're managing this, because it's massive systems change work. It's in a couple of phases. We've just completed phase 1, which is we've agreed, negotiated, it's taken a long time, shared roles and responsibilities, a shared promise to those children, which we're describing as an ambition. You will always be our priority. We will not fight over money and delay your assessment or treatment, those kinds of things. You probably saw on Twitter this week that that's had a lot of coverage both regionally and nationally, so do take a look at those arrangements. We also negotiated, and all of this was approved by those with statutory responsibility on the 4th of December last week, a shared tariff arrangement for CCGs, which is explicitly to stop overcharging between regions. So please don't charge us £4,500 or £5,000 for an assessment for a child, which should be costing in the region of £240. It's no good for that child, it takes away from the pot, and it's creating a market economy we don't need. Now that we've got all of that negotiation work complete, we are now rolling these out nationally across the regions in the UK with the support of Catherine Pugh and Kenny Gibson and the support of LGA, Children's Services Advisors and ADCS. So that's good. What we're doing in the South East is going to become the foundation for national change. We're also talking to the NICE committee about getting this embedded in the Looked After Children's NICE committee guidance. Wave 2 is the next bit for us to think about, and it begins in January 2021, but it's really helpful for us to think about it now. The first bit of that is we're working to redesign what you would describe as the social care, the social welfare accommodation for these children in 4 parts of the South East where we've got the most children, so places like Kent and Sussex, etc. We're working on that. And that's really the local authorities giving over their existing budgets to say, could we design emotional health care within that provision from the outset with providers? And we're very grateful to Sam Allen from Sussex and from Nick Broughton from Oxfordshire as Chief Exec, sitting around that table with Vanessa Fowler to kind of do that work together. The second part of Wave 2 on the next slide is really where I could really do with your help. When we look at, and please do go on, James, when we look at the evidence of impact for the rest of the life course for our children in care, they become your frequent flyers in adult mental health context. They're far more likely to be in crisis. They're far more likely to be in inpatient care. They're far more likely to be in your IAPT perinatal, personality-related services. You'll find them there. And that's why the community mental health transformation proposals and the new money says, please, will you explicitly consider care leavers? Our experts by experience, we've got a number of care leavers working with us South East wide on this work. What they say to us is very humanly, look, it wasn't until I was 25 and I had my first place to live by myself, or until I was 31 and I had my first baby, or I lost my job at 28, or my world fell apart when I was 41, or something happened here that I really started to think about the impact that the trauma I had lived had on me. And at the point that I was an adult, there was nothing there bespokely to support me. Picking up on Lila's point, that was trauma informed, that understood in the same way that we would for veterans, really, what that life course, what that life experience does to you, what you need in terms of support. I'm asking for your help, really. As we look at 0 to 25, as we look at community mental health transformation, would you work with us so that everything we've learned about children in care, we've got really detailed analysis for these children who will be our care leavers of the next generation, can inform what you're planning? We're really happy to share that. On the next slide, you'll see the specific kind of questions that we think really could do with some consideration. So James, just keep pressing the buttons. James, thank you. We think we probably need to understand with you the need, cost and volume of care leavers in your systems. That might require us to routinely flag care leavers in the data management systems that don't currently hold that. We've done some early thinking with colleagues in some of our provider trusts and started scoping some of the questions that might require. So the offer is, if you want to talk to us about that, if we could sit alongside you and help with that thinking, would you let me know? My email address is just on the bottom of this slide, and we'd be most grateful to have that conversation with you. Thanks, James.
Hold on, I'm here. Thanks, Andrea. Sorry, I didn't mean to trample all over your final point and come off there too quickly. I'll try and bring it back up if I can. I'm sorry. However, you make a very, very good point. And let's actually, I will share that final slide if I can. Yeah, Andrew and I have been having conversations about the impact of care leavers in that sort of wider programme aims of 0 to 25 transformation, as well as the community mental health transformation. She quite rightly pointed out that these things can be triggered through through different life experiences at any point in life, and therefore and they can turn into very complex complex issues. So it sounds as though what Andrea's giving us there is the opportunity to say that we do have an indication of who numbers or types of experiences that are out there, and so therefore it would be a crucial part of the community transformation planning to ensure that this cohort are better supported, certainly recognised and better supported, I should say, in these planning, in this planning. And similarly, I think we've heard a lot about that today, haven't we? We've heard about complexity, we've heard about intersections of services, we've heard about difficulty navigating systems and navigating care pathways. And I'm really glad that we managed to bring so many interesting speakers together today that gave us both the service user and family perspective, what it's like for our teams on the ground that are working in very sort of complex and trying to work as closely as possible to individuals and families, and then describing those potentially more at-risk individuals, including young people generally, and trying to young people in mental health services and how they're brought through into adult services, how they're supported appropriately, and then even sort of going further into that about sort of what it means for the care leaver cohort, and how important it is that we try to get a handle, or at least show that we have a handle on this on this cohort, to further support and address their needs and address them holistically, because I think a lot of this, not talking out of turn, life experience, and as I sort of label it, life crap, sorry, but that they are things that will routinely get in people's will affect people's approach to life and affect people's considerations of their situations. So we have to be prepared, and both Layla and Andrea both mentioned there about trauma-informed care being as important, if not more so, when it comes to mental health and working with previous trauma, and how people react and how their emotional well-being is supported as well. So thank you very much, everybody. Again, as Andrea said, it's been a long day, I'm sure, as part of a long week in the run-up to hopefully a more relaxing time over Christmas and New Year for you and your families. I don't think we are running a session on the 23rd. I think people will be finding their way around the Christmas online shopping, no doubt. Please do stay safe. We will be returning in the new year with these calls every fortnight. We appreciate your guys' involvement. If you do have any questions or any other queries based on today's call, there are emails available and you can reach out to us. We'll also make sure this recording is shared as well just before 4:30. So therefore, thank you, everybody, and appreciate everyone, including our speakers, and our taking the time to talk with us today, and for you guys in actually attending and sticking with us. And I hope you have a rest of a good day and a nice evening. So speak to you all soon, and all the very best for the coming weeks. Thank you.
Thanks, James.
Thank you.
Thanks, James.
Thank you.
Thank you.